I'm Christy Ballantyne, Chief of Cardiology at Baylor College of Medicine and co-chair of the Cardiometabolic Health Congress.
I'm Leslie Cho. I'm the section head for preventive cardiology at Cleveland Clinic.
Well, Leslie, we have wonderful data with guidelines, and the guidelines emphasize high-intensity statin for all of our patients who are in the very high-risk category. However, I know your experience and my experience, you're getting referred a lot of patients because they don't tolerate high-intensity statins, or they don't tolerate it. Maybe they've had bad experiences. And I know that for our audience, this is a big problem. Can you share some of your pearls of wisdom from having dealt with this problem over and over again? What are some of the things that people should be looking at when they first see the patient, and how do they get them to try to at least get them onto something that's going to be beneficial?
So statin intolerance is such a common problem, as you know. And when we look at real-world data, it's around 5 to 10% of people who can't tolerate statins. And usually it's high-intensity statins, and usually patients are elderly or frail. But there are other sort of common things that predispose you to not tolerating statins. And some of them are medications we put patients on, like verapamil, amiodarone, digoxin, some of the antibiotics. And then there's some patient characteristics like alcohol use or some genetic predisposition too among families. But I think one of the most important things is to take a good history and physical, right? And did it start after you took statin? How long did it take before it started? And what are the muscle groups that you are having issues with? And does it go away after you stop statins? But I really think that critical part of diagnosing somebody with statin intolerance or is H&P, just a standard good H&P.
Yeah, that's very important though, is they'll come in, but then getting back to this information is, when did you start the statin? What was it? What was the dose? What were the symptoms?
Exactly.
Did you actually have rhabdomyolysis or things like that, where certain ones we're really more worried about than others in terms of it. So I think that's some wonderful advice. So you've done this, you've gotten the information. What's the next step?
So I think the important next step is, okay, so you went through and they truly are statin intolerant. I think some of the hydrophilic statins are much better tolerated than the lipophilic statins. And so the hydrophilic ones are like rosuvastatin or pravastatin. We at the clinic started once a week. So we started once a week, rosuvastatin once a week. And then if you're able to tolerate it, then we go to twice a week after a month. And then if you're able to tolerate that, then we either escalate the dose or we escalate the frequency to get to an LDL goal that is applicable to you.
So I think a really important point, someone's had a bad experience, we're trying to persuade them this is going to be better. And I know that I'll sometimes I might have been on 80 milligrams of atorvastatin.
Yes.
So I can say, listen, we're going to go with 5 milligrams of rosuvastatin. If they're really clear, it says, we'll cut it in half.
Yeah. You'll
take 2.5 milligrams, and we may do that twice a week, once a week. So this low-dose concept, I've had success, but you've had a lot of success in terms of low dose and then adding other agents to it, right, Leslie?
So, I mean, I think you're absolutely right. It's meeting patients where they are. It's having sort of that shared decision-making. I know everybody likes to use that word, but really, truly becoming on their side and then having a plan together. Because if you say a bunch of stuff and they don't buy it, they're not going to do it at the end of the day. So I think that's important. And then we really like ezetimibe as in combination or some other modality, and soon there'll be a bempedoic acid, maybe, who knows. But I mean, there are so many things, but I think really meeting patients where they're at and then being on the same page and having similar goals. There's no amount, people talk about, you and I know plenty of people who don't believe in statin intolerance. It's a real thing. If you don't want to take it, what are we going to do?
If somebody feels bad, they feel bad.
Yes.
And it'd be like you telling me, I'm having a bad day, and I'm saying, well, that's just in your head.
Yeah.
Maybe it is, but you're having a bad day. So the bottom line ends up, we have to listen and work with them. And now, the other tip that sometimes people get frustrated, you may not get as far as you want. We have the other options you mentioned.
Yes.
We've got ezetimibe combination, maybe one in the future, bempedoic acid. If they've got FH or coronary disease, we might be able to use a PCSK9 in there,
Absolutely.
and with very good results.
Yes,
You've done the work on
yes.
that, showed outstanding results also.
I mean, I think PCSK9 is a game changer, right? I mean, it's really a game changer. It proven in Gauss 3 in statin intolerant patient intolerant to 2 or more drugs that they're able to tolerate. The discontinuation rate is like 0.7%. Like unbelievably good.
Right.
And so I think it really is a game changer. But I think the important lesson from Gauss 3 is that in people who are intolerant to 2 or more, 60% of them actually were not truly statin intolerant.
So that's why you really this extra effort to get them to
Yes.
take it. And then the other one ends up sometimes, it's important, this is the cardiometabolic comprehensive approach towards patient care. I've had some people say, listen, okay, we couldn't, they're pushing back. Can we improve your blood pressure control? Can we do better on your diabetes?
Yes,
and so you might get them to make some progress there, and then later on they come back with it. As you said, we have to work with them to try to reduce their risk for it.
And risk is cumulative,
It's
right?
cumulative.
It's totally cumulative. Your risk as if you just have hypertension versus hypertension plus lipids plus diabetes, I mean, it's really cumulative, additive. And I think it's really important, we think about this so often, like when you only have that very precious 10 minutes or 15 minutes with them in the office. It's really important that when they leave, that they leave with a similar plan as you.
Right.
Right? Because we don't see them.
So I always end up with it when I have the plan printed out, we go over, we agree to it.
Yes.
Something to follow up. And it may be one final thing. We both get referred some of these patients. Some of them they're older and, particularly some of the older women, very health conscious. But what about CAC scoring sometimes?
Yeah. It's funny because you and I have a mutual friend who hates CAC score.
Yeah.
But I think if you have a 70-year-old woman, as you said, whose calcium score is 0, my God, we don't have to be pushing statins on them.
So then you end up, we go, let's work on your blood pressure or something else. So anyway, so Leslie, it's always great to see you, but I think these are really tremendously helpful, practical points. We know it's that we need to do something in terms of the lipids. We can't ignore them, and that basically you can, with a stepwise, good evaluation, stepwise approach, you've shown that you can do this and get good results with patients.
Yes, it really is true. I mean, I think one of the wonderful things about conferences like this, but also like treating patients holistically, is the importance of getting at every single risk factor,
All right. Well, listen, thank you, Leslie, and I hope it's been of use to you. We're here from the Cardiometabolic Health Congress talking about how we can get our patients who are high risk to get their lipids under some way, even though they have statin intolerance.